Hi, good afternoon. Can you all see the slide?
Yes, we can. Maybe we can just enlarge the screen, Dr. Premala.
Okay, all right. Okay. Okay, better?
Yes.
All right. Thank you, Giri, for having me and the geriatric team on board for this medical CME sharing session. Actually, we didn't propose to the national geriatric team. It was a proposal that came from KKM, and then we actually sat down and discussed about the role of CFS and how can we get something that is more appropriate for our local setting. So, so one of the ways to educate people about CFS is to have this kind of teaching sessions. So we can actually share our knowledge. So today we are just going to speak about clinical frailty scale and its application in clinical practice, especially in the context of COVID-19. Now we've been in dealing with COVID for the last 10 months. And for doctors who have never heard about frailty, never heard about clinical frailty scale, suddenly it's a tool that we are supposed to use to triage our patients. And we are supposed to, make important clinical decisions about allocating, health resources when it comes to COVID-19 management. Many people are not familiar about frailty, and now they are supposed to do this frailty assessment. So today I'm just sharing some of our knowledge so we can use the scale appropriately, especially in complex cases, and in a disease that we are still learning the consequence, the effects, and the progress of the disease itself. So let's go on. So our learning outcome today is actually just to introduce what is frailty, what is clinical frailty scale, how to apply this CFS scale in our daily practice, and how to use this tool as a multidimensional assessment tool so we can appropriately choose the patient to escalate which kind of care that we want to give them, and to identify people who are at risk of poor outcome early, so we can actually lessen the burden on the healthcare system. So what is frailty? When I was a junior medical officer, I never liked to work in emergency department, especially when I have patients who are especially when I'm seeing older patients. I just don't understand why are they coming with different presentation compared to the disease that's making them come to ED. For instance, we see a lot of older patients coming with confusion, falls, muscle weakness. I mean, how to know what is the cause when they come in with, muscle weakness? How can that be a cause for them to come to ED? That was the thing that was going on in my mind when I was a junior doctor, and when I had no idea what was frailty. So for doctors who have who were like me many years ago, and who didn't understand why the older person present differently, like younger patients, when they have UTI, they come in with fever, they have this urea, they have increased frequency. But the older person, even though it's UTI, they come in with confusion, or they come in with falls, right? So I want you all to imagine a chain that is which has a lot of links. And imagine this chain. Along this chain, there'll be some links that are stronger than the other. There may be a link that is the weakest among the rest of the links, right? So now when we pull the chain apart, the weakest link will give way, right? So when this weakest link gives way, the chain will snap, right? So no matter how strong is the chain, it is only as strong as the weakest link, right? So our older patients are similar to that chain. They are in a compensated state between all these systems in their body that are sort of like, in a compensated state. So if there's any trigger, and if one of the system is weaker than the other, and this system, for instance, the brain is weaker than, you just say, the heart, so they will manifest with confusion rather than heart failure, right? So it's the weakest link, the weakest system that will make them manifest. And they don't manifest typically because they are manifesting the weaker system rather than the trigger. Okay, so frailty is actually a multifaceted, it's a complex clinical syndrome that makes the person has increased vulnerability to stressor, right? So they are not going to come in as your typical 20-year-old, 40-year-old to ED, right? So why does older person have frailty? You know, they can have frailty because of social demographic influences. They can be due to psychological factors, nutritional issues, polypharmacies, diseases and its complication, and low physical activity, right? So when you have frailty, is it the same as aging? No, it's not synonymous with aging, nor is it inevitable result as part of aging. But having risks of frailty does increase with age, right? And is frailty and multimorbidity, what is the relationship between them? They are distinct health concepts, but they are definitely interrelated. Frailty can affect multi-body systems, which can make an individual susceptible for multimorbidity. And multimorbidity can lead to increased depletion of an individual's reserve, thus increase their risk of having frailty. So frailty is an important geriatric syndrome which is dynamic, which is fluctuating with time, and it reflects a multi-system dysfunction, right? So for when somebody has frailty, they can already have different kind of clinical consequence, like how the disease present and how often more than one illness is active at a time, and how these people are going to tell us about their symptoms or cooperate with our examination, or how certain drugs going to work on them, and how we're going to see our treatment success rate. So for somebody who has frailty with upper GI and somebody with no frailty and has upper GI, even though we're going to give them the same kind of assessment, the same kind of treatment, we may not see the same success rate, right? So it can manifest as decreased mobility. They can come in with weight loss, come in with decreased muscle strength or decreased energy levels. And most of the time when they come in as outpatient with frailty already setting in, they will come in with increased dependence on their activity of daily living. So activity of daily living is actually can be divided into basic activity of daily living, which means your own personal care, bathing, dressing, toileting, feeding, or instrumental activity of daily living like finance, driving, household chores. So if you see somebody in your clinic with time, they keep needing more and more help with their ADLs, means that some form of frailty that is already setting in. So why is this important? Why is it important for us to pick up who has frailty and who does not have frailty? So somebody who has frailty, they are more likely to have more pronounced deterioration in response to even a minor illness. So if you look at the graph, all right, so the blue line is for somebody who has no frailty and the red line is somebody with frailty. So when they have minor illnesses, the deterioration of their their function goes further in a frail person until they lose their independence. And as they get better, they may rebound or they may not go back to where they were before this. And the timeline for them to improve after this minor illness is much more prolonged compared to somebody who does not have this frail issue. Right? So as we saw from the slide, so they take a longer time. They become more dependent with the minor insult. So of course, we tend to see readmission rates. They have longer hospital stay. Their mortality is going to be higher in those with frailty than those without. The chances for them to be discharged home is lesser, and the chances for them to be discharged into an institution is going to be more. And they will report new disability. And of course, all this time, they're still sitting in the hospital and making use of the hospital care. So how does frailty affect COVID? Okay. So we have few factors to consider. On one side, we have to think about COVID and its effect on our healthcare system, which like in Sabah, we saw there's already a demand in acute care services in the hospital. So we need to, get more beds available, more ICU space available, more staff available, and of course the equipments, right? And we are seeing a demand which is more than the supply. So, what did we do? So we expanded our ICU care into non-ICU space. We are utilizing non-trained ICU staff to care for ICU patients. We are setting up field hospitals to cater for non-COVID patients. And of course, the plans to obtain and conserve and increase the efficacy of our physical equipments. So this is one part, which is COVID and the demand on the healthcare system. So on the other side is actually our aging nation, right? So by 2030, we are already an aged nation. So the number of older persons coming into the hospital doors are going to go up. And when you see older persons, and the large proportion of them are going to be older person with frailty. So which means we are going to keep them longer because of the frailty effects. And the third factor we have to consider that this is COVID, right? So we're going to learn new things about COVID and its post-inflammatory response effects. And we did see COVID and its comorbidities, how it affects our management. So it's important for us to understand which older persons are critically ill with COVID disease that can withstand both the disease and also the treatment and being in ICU. Because there are so many parameters here that we have to consider to see who is going to come out of it at the end of the day. Yeah? So what is CFS? So it's a 9-point global frailty scale that looks into mobility, energy, physical activity, and function. Okay, but understand that this CFS score is based on the person's condition 2 weeks prior to the presentation, not on the day of presentation, not when you're looking at them at that moment, right? But it's 2 weeks before their presentation. And why we are opting for CFS is quick, is easy, it's less time consuming compared to the other tools, right? It can be used by any trained healthcare worker, your nurses, your therapists, your housemaids, your doctors, right? Anybody can use this tool as long as they are trained, and can be used to predict outcomes of older person hospitalized with acute illness. Also predict inpatient mortality, and we can target our resources within the hospital. So what are the information we need to get to use this tool, the CFS tool? What we need to know is about their physical fitness, whether there's any active disease symptoms, what's their level of dependency, and what's their cognitive status. And all this information we can get from history. What's his history of presenting illness? What's the past medical history? What are their comorbidities? What's their social history? What medications they're taking? Are they having some limitation in their physical status? Are they using any mobility aids? What's their cognitive status? And what is their support system in the house? Right? So this is the tool, Clinical Frailty Scale. This is version 2, recently released, I think in September this year. So it has 9 stages in Clinical Frailty Scale. So it's easier to classify them to 1 to 4, 5, 6, 7, and 8 and 9. Okay. So 1 to 4, they are independent, right? They are independent. How do you differentiate between 1, 2, 3, 4? Is number 1 is 1, 2, 3, we will decide which level they are based on their exercise regime, whether they exercise regularly, whether they are exercising occasionally or seasonally, or whether they are not on regular exercise except routine walking. So that's 1, 2, and 3. Number 4, they are still independent, but they have symptoms that limit their activity. For instance, they have knee pain, so they can't walk or they can't cook. So the active symptoms limit their activity, so they fall into stage 4, living with very mild frailty. Right? So 5, 6, 7, it depends on their ability to do their activity of daily living. Number 5 is they are independent in the home. Out of the home activities, they need some help. Okay, so that's number 5. Number 6, they are independent at home, but all activity outside the home, they need assistance, right? And within the home, they need very minimal assistance like bathing or staircase, right? Number 7 is they are completely dependent on their basic ADL. Even though they're completely dependent, they are not at high risk of dying within the 6 months, right? So 5, 6, 7 is IADL, BADL, but not at risk of dying. Why is it important to differentiate between CFS 6 and CFS 7 is the all-cause mortality during admission. These numbers are for non-COVID. So for CFS 6, all-cause mortality during admissions is about 6%. But CFS 7, this almost doubles to 11%. So we have to make sure that we are differentiating 6 and 7. So let me repeat. 6 is those who need minimal assistance within the home, but all outside activities, they need help. Number 7 is within the home, they need assistance. They are completely dependent on another person. So 8 and 9, 8 is they are completely dependent, same as 7, but they are approaching end of life. That means even if they get community acquired pneumonia, they may not recover, right? So that is number 8. And number 9 is they already have a disease where the life expectancy is already less than 6 months, but otherwise they may not be frail. It means they may be walking around, but they have a stage 4 pancreatic CA. So those are the people that you put them into terminally ill, right? So when you use this scale, about 80% of our population will fall into these separate stages. But the rest, they may fit into 2 different categories equally well. So if you do find patients who are fitting into 2 different categories equally, so we choose the one that is at a more dependent level. That means if they're between 4 and 5 equally, so we choose 5. Yeah. So CFS can also be used for patients with dementia. The degree of the frailty corresponds to the degree of dementia. So what is dementia? Mild dementia is forgetting recent events, repeating the same story or repeating the same question again and again. Moderate dementia is their recent memory, that means whatever that happened recently is impaired, but they can remember what happened 20, 30, 40 years ago quite well. And for personal care, they need some prompting. That means like you need to prompt them to have their shower, right? So those people falls into moderate dementia. And severe dementia are those who cannot do personal care without help. Means they are dependent on somebody to for their personal care. And very severe dementia, the last stage, they are mostly bedbound. So how do we apply CFS? As I said earlier, it can be done by any healthcare professional who's been trained. And it is 2 weeks before the current acute illness, not on the day. I'm being repetitive also. The CFS need to be done and their baseline is supposed to be 2 weeks before the current acute illness. And whoever who is deciding on a clinical management, the appropriate next level of care for this patient, they must check the score whether it's accurate, right? Because it is quite fixed who falls into which category. So if there's somebody junior who's not familiar with the CFS scoring and they wrongly score the patient, and if we don't confirm that, then we may put them on a different treatment plan, which may not be appropriate for the person. If you don't have this information, please do not do the CFS, right? Defer until we have the information available, right? So that is how to apply. But again, this is a tool. It is not a perfect tool. We have its limitation. So in a non-pandemic, non-COVID era, geriatricians use CFS as part of a multi-dimensional assessment rather than a screening tool. It is not validated for those less than 65 and those with learning disability, right? NHS suggests to use CFS as a decision support tool. But remember, it is not perfect. It should not be used in isolation. We must use our clinical acumen to also plan for our management. You cannot use that as a single tool to decide. And if you can see, the limitation is the patient's level of disability heavily weighs the CFS. And again, because this is a judgment call, there may be some inter-observer variation. Right? So these are the limitation of CFS. It is not a perfect tool. And we can only use it for those more than 65. So because this is a judgment tool, there will be some biases, right? So for instance, a leniency effect is when you know I'm marking the person and I'm giving them marka kesian. It means I am forgiving and I want to give them a better mark. So that is a leniency effect. A central tendency effect is, you know, when we are when we do not want to choose the extremes of the marks. That means we are settling for everybody gets a 5 or a 6 rather than 7 or 8. And halo effect is first impression. That means when I first see the patient, I see them on the bed, on the oxygen, and I straight away mark them at 7 or 8 without getting a proper assessment. And primacy effect is to remember the information that is presented first. That means when you're talking to the carer, they say, oh, the patient is well. So as we dig and we get more history, actually patient is not as well as we thought. But because of primacy effect, we tend to rate them, give them better CFS score. So that is one part of the bias. The next bias is response bias, and the most common one is a recall bias. This is when patient or caregiver reports inaccurate information to the healthcare worker, whether intentionally or unintentionally. So frailty misconceptions. So they may see it as a weakness. They may see it as a point that they're going to lose their freedom. So they don't inform you they don't give you the correct information, or where the patient has no insight of his limitation. So, and the children are not contradicting because this is out of respect to the patient. And sometimes there's over-reporting of frailty when the carers are burnt out, where they're actually 5 or 6, but they say it's 7 or 8. right? So these are the response biases that we need to avoid when we are doing the CFS. So the next part is case scenarios. I am going to call upon Dr. Naresh to proceed with the case scenarios. We have about 5 cases. Naresh, are you?
Yep, I'm
okay,
here.
All right.
Premala.
Okay.
Okay. Hold on. I'll also share the same slide. Okay, so we'll do the case scenario. Okay, so this is case scenario 1. Why we're doing this case scenario is so that maybe we can just have a little practice to see whether we are familiar with some of the concept that Dr. Premala has shared about today. So in case scenario 1, we have Mr. M. He's 74 years old. He lives in a double-story house. He is independent in both his BADL and IADL and continues to drive around town. He is still paying his bills online and regularly connects with his friends through WhatsApp. Both the bedroom and the bathroom are upstairs. His asthma is under control with regular Symbicort. Hold on. And he does grocery shopping and attends Club Pesara Kerajaan once a week to keep in touch with his retired colleagues. So maybe you can just think about it for a few seconds and see whether you get a similar answer. So this is actually somebody who has a CFS 3. He's actually managing well. So why we say CFS 3 is because we can see there's a few things going on. So we go through the 3 main things that Dr. Premala talked about, which is your physical fitness, your dependence, and your cognition. So this gentleman, in terms of fitness, his asthma is well controlled, but he's overweight and he does not regularly exercise. So that's why he's in CFS 3 and not one or two. In terms of dependence, he's independent in both his BADLs and IADLs. In terms of cognition, he's a very robust person. He drives and he manages his finances well. So this is an example of a well patient who is in CFS 3. Then next we go to at clinical scenario 2. So we are going to talk about Mr. Y. He's a 75-year-old gentleman. He has underlying type 2 diabetes, hypertension, AF with heart failure, and osteoarthritis, and who's under follow-up in KL. So he stays on the first floor of a shop lot, and he's a retired shopkeeper, stays with his wife, his son, and his daughter-in-law, and 2 grandchildren. His daily routine involves mostly staying at home, watching TV, and taking naps before and after lunch. Occasionally, he walks to the coffee shop nearby for breakfast and buys 4D numbers. He used to do this on a daily basis, but for the past few months, it's been only 1 to 2 times a week. Besides the knee pain, he feels tired most of the time, and it's quite cumbersome for him to go down. He's independent on his BADL, but he doesn't do any of household chores, as his wife and daughter-in-law are the ones doing the chores. Family didn't notice any problem in his memory so far otherwise. So just take a few seconds to think about what this gentleman could be. I think this sounds like one of the usual case scenarios we get on a day-to-day basis. Somebody who is always coming in with the regular hypertension and all that. So in terms of the 3 things, again, the physical dependence, cognition, and his dependence, or what it's like. So this is a CFS 4. So it's somebody living with very mild frailty. So you can see in the physical fitness, he's a sedentary gentleman. He does have active disease of his symptoms, so he still feels tired upon waking up, and he has occasional knee pains. In terms of dependence, he's still an independent person. But in terms of his cognition, it's still intact, and family didn't notice anything. So you can see the main difference between here and the guy before. This gentleman, he's already having some slight limitations due to the pain and the tiredness. The next one we'll go to is case scenario 3. So this is Mr. M. He's an 81-year-old army man. He has AF hypertension, and he recently underwent a CAPG. He has lumbar spondylolisthesis that frequently gives him a backache. Despite this, he still manages to walk to his farm, which is about 200 meters from his home. He's unable to do any farm work, however, and he has hired a new gardener to maintain the farm. He is independent in his BADL. He relies on his wife for driving, cooking, and paying the bills. He occasionally forgets his medications, so now she supervises him. He has a smartphone, but he only uses it to call out independently, but he's not able to use the other features of his phone. So again, see, this gentleman, he's somebody who's still independent in his BADL, but he already needs to rely on his wife on some of his important aspects of his daily life. So again, this one, the answer would be he's somebody with CFS 5, living with mild frailty. This guy, his physical fitness, his independent mobility, but limited to his back pain. He cannot undertake heavy farm work, but he still manages to walk regularly without an aid. In terms of his dependence, he relies on his wife for driving, cooking, and paying the bills. She supervises his medication, but his BADL is otherwise completely independent. So that prevents him from getting a higher stage. So his cognition, he still manages to use his phone to call out, but he occasionally forgets his medication. So this is an example of somebody who could have CFS 5. In case scenario 4, we have somebody who is an 82-year-old gentleman, retired technician, lives in a double-story house. He has hypertension, gouty arthritis, OA, type 2 diabetes, and CKD. Otherwise, he's ideal, independent, good cognitive function, but intermittent gouty attacks, 1 to 2 times a year. But by 2018, his elder daughter passed away. He's low in mood, but it didn't affect his function yet. Subsequently, in 2019, he's ideal, independent, drives to visit family members in Perak and KL, but his nephrologist informed he may need RRT soon. By 2020, he's already unable to drive, unable to go down the 2 floors of his home due to the joint pain and fatigue. And by 2020, June, he had a fall due to hypoglycemia, and since then his family has taken over his medication and supervise him during showering. So this is one of the similar scenario that we do get now and then in our emergency department. So in this gentleman, he will be probably somebody with CFS 6, living with moderate frailty. His physical fitness, he has so many disease, hypertension, gout, OA, diabetes, but he's still able to ambulate in the house, but is limited due to fatigue and fear of fall. In terms of his dependence, he's independent on the basic ADLs, except he needs supervision during his showering and medication. He's unable to drive and leave house alone without any assistance. So we can see that he's mainly, at home only he can do certain things, but his cognition is still intact. So this is somebody in an example of CFS 6. In case scenario 4, Mr. A, a 66-year-old gentleman, so he previously worked as a porter in Mount Kinabalu till the age of 50. He developed a left MCA infarct a year ago with residual right-sided hemiparesis. Currently, he needs one person to assist him in dressing, bathing, and transferring from bed to wheelchair. He is on Ralph's tube since the stroke. His weight and mood has always been good despite the stroke. He can't remember his childhood friends, and he can remember his childhood friends and school days, but frequently forgets his children's name. He keeps repeating his request to go out of the house, and when the family does not fulfill the request, he gets angry. And his son occasionally brings him to the park. Stroke is something we see very regularly. So this is somebody who has CFS 7. In terms of his physical fitness, he has residual neurological deficits. And the main difference will be his dependence. So him is different from somebody with CFS 6 because he's dependent in all his basic ADLs, including his feeding. And also the other thing in terms of his memory, it's moderately impaired because he doesn't remember his children's name, and he has some BPSD features, but his long-term memory wasn't affected. So those were some of the examples, on how one can actually use the CFS score. But here are some actually tips to how get a better value from the score. So remember the point number 1, as Dr. Premala emphasized a few times, is all about the baseline. We need to ask what they were like 2 weeks ago prior to the illness, rather than taking what they look like there and then. Number two is history is very important. So we need to really get a proper history, whether it's from the patient or the caregiver or a family member. Number three, we have to trust what maybe another colleague or doctor is saying to us, maybe regarding his CFS score. But if possible, the decision maker should also verify the score, because sometimes we are going to use information like this to make important decisions, especially during the COVID-19 or a pandemic time, where we may need to make important decisions such as whether patient goes to ICU or not, whether he's going to be intubated or not, or whether it's just going to be palliative or end-of-life treatment. Next would be the score is used for somebody who's only over 65. So we try not to use it in a young, maybe 20 or 30-year-old, because it's not validated in them. Point number 5 is those who are terminally ill. So we try not to forget that. So those who are terminally ill, they may appear well on the outside, but underlyingly they may have a terminal cancer or something. So we need to consider this group of people as well. Point 6 is having a medical problem does not automatically increase the score to CFS3. So meaning you may have somebody with hypertension and diabetes, but they can go for a jog, maybe a 5 km jog every day. See, some of them are really well, despite having one or two diseases with them. Don't forget the vulnerable age group, which is CFS4, because these people are in the transition, of being somebody who's actually independent, who later on may progress to actually becoming somebody who is dependent. Dementia doesn't limit the use of the CFS. So in dementia, you have mild, moderate, and severe dementia, and it generally maps onto CFS 5, 6, and 7 respectively. So, we can apply the principle in dementia as well. And lastly is we need to drill down into changes in function. So we consider more complex activities of daily living, such as cooking, managing finances, and all that. The focus is on change of function. So, for example, if somebody who, let's say a gentleman who's never cooked in his whole life, when you ask them, can you cook? And they say no, it doesn't mean that, they have deteriorated in this function. It only means that, he probably didn't learn cooking his whole life. So this is just a simple table on comparing the CFS score with the length of stay, readmission rate, and inpatient mortality, as was previously discussed. So we can roughly see that, as you increase in stage of your CFS grade, your average length of stay in the hospital is usually increased as well. Your readmission rate also goes up a little bit, but what's the most significant is look at the inpatient mortality, especially once you pass CFS 6, every stage you're going up by about 10%. And in terms of the management, when you are in CFS 1 to 6, your main goal would be to detect and manage the geriatric syndromes like delirium, because this score was mainly used in those who are above 65. But when they are in CFS 7 to 9, we probably need to think about palliative versus restorative care. So this is where our clinical judgment comes into play, where we think on what to do with the patient.
And this table and the sorry, Naresh, and this table is we are getting all these numbers when we are not dealing with COVID. Yeah. So this is pre-COVID numbers. So this is admissions for, maybe community-acquired pneumonia or cellulitis or UTI. These are not numbers for COVID. Yeah.
Okay. So now just for some further information. So the case scenarios actually that we put up, this is the link for a Google Drive, where if you want to practice again or just try to think about it more, you can just have a look at it. In our day-to-day practice, if you are having difficulty in applying the CSS, especially for very complex patient, or if you are in a casualty, or you just need some further help, I just can consult the geriatrician or a senior clinician to come help make the decision. And also, if you want to have further training, you can check out NHS Specialized Clinical Frailty Network. You can just go to the link. You can actually do the quiz there, and you can even get a certificate that you've done some CFS training. This is actually just to show that there's an app as well. So Kenneth Rockwood was actually the guy who did this Rockwood CFS score. And this app is actually very easy to use. You just have to answer the questions and the score will come out. There's even some video resources in the app to actually, give you more information about it. And finally, this is just some of the references that were used. And that's the end of our sharing today. Thank you very much. I'll stop sharing here.
Thank you, Naresh, for doing part 2.